a joint effort between the Behavioral Health Clinical Program and the Pediatric Guidance Council. And we had a little group together, and as we started to talk about this, we realized that we had a lot to learn. I'm certainly not an expert in autism, as some of the people that you're going to be hearing from are. And we thought that there was a number of things that we needed to do. One of the things that we needed to do was we needed to get a sense of what the important issues were in the community. And we thought that doing a grand rounds and giving people who are here at grand rounds an opportunity to ask questions and make comments as part of our presentation would be an ideal way for us to learn something and to help work on this initiative. We also learned that services for autism is really a community issue. It's a very important issue here in Utah. And that if we're going to make any progress in this area, we really need to work together as a community. So I want to introduce the group of people who are going to be presenting today, and really very happy that all of these people are participating. It's going to start with Dr. Paul Carbone, who's very well known here in the Department of Pediatrics. He's written and presented extensively on the diagnosis of autism spectrum disorder, both locally and nationally. He has an active clinical practice caring for these individuals in the university, and he's going to provide us with an updated review of the literature. The second presenter is Dr. Lisa Palmieri, who's a local pediatrician, works in Intermountain Altaview Clinic, and has developed an emphasis in her practice for the care of patients with autism. And she will discuss her experiences and how she tailors her practice to meet the needs of these patients. Ms. Erin McQuivey is a manager in the rehabilitative services here at Primary Children's, a program that cares for a significant number of individuals with autism, typically in the context of speech, language, sensory, and fine and gross motor therapy. She will discuss the role of subspecialists in the area of these patients, with some assistance from me and a few slides talking about psychiatric care. Mr. Colin Kinsbury is the Autism System Development Program Manager in the Bureau of Children with Special Healthcare Needs for the Utah Department of Health. And he will discuss the relative availability of community supports for these patients. I'm very happy to have him here. And last but certainly not least, Ms. Cheryl Smith, a parent and community activist and past president of the Autism Council of Utah. She will give us a very personal and important perspective on the needs of this population, something that she and her husband understand very well, and the wonderful care that they provided for their son over the years. We also hope to have about 15 to 20 minutes at the end of these presentations for comments and questions. I'd like to start with Dr. Paul Carbone.
Good morning. Appreciate the opportunity to be here. I think, Rich, you were going to talk about that, but there's our objectives. And there's me. There's me. So that's not a picture of me. So I think our myself and my co-presenters would like you all, first and foremost, to know that children with autism are lovely people with many, many, many strengths. But the DSM-5 committee would also like you to be aware that they have essentially two core deficits in the area of social communication and social interaction, and the presence of restricted interest and repetitive behaviors and activities. So that's the DSM-5 definition of autism. Autism is also an extremely common neurodevelopmental disability. The CDC estimates that about 1 in 68 children in the United States have autism spectrum disorder, which is about 1.4%. And it's certainly true that whenever you say something about autism, it instantly becomes out of date, and I'm proving that here. The CDC is set to release prevalence data like literally in hours. So what I just told you is now incorrect. So in my quick review of the literature, I'm going to try to keep my comments pertinent to pediatricians who take care of children with autism in their practice. And we'll do this in 3 short acts. So the first 2 acts are surveillance and screening. Those are things that pediatricians do to identify children with autism at the earliest of age. And then we'll focus a little bit on ongoing care, which is what we do as pediatricians once the diagnosis is made. So early identification of ASD is important because of the expanding and wide availability now of early and intensive behavioral and developmental therapies that improve developmental and functional outcomes. The median age of ASD diagnosis in the United States for children is approximately a little bit older than 4 years of age. And so that raises the question, well, could we identify autism at an earlier age so that we could get these children in effective treatments earlier? And the answer seems to be yes, in that within the last 10 years, there have been a growing number of prospective studies looking at high-risk infants. Those would be baby siblings or infant siblings of children with autism whose development is tracked carefully over time. And what those studies have shown us prospectively as we watch their development unfold is that you see reduced levels of social attention and social communication and a whole bunch of other early signs of autism by the age usually of between 12 and 24 months. So we certainly could theoretically be diagnosing these children younger. This is meant to be an incredibly intimidating long laundry list of early signs of autism that have been discovered through this Baby SIBS research consortium that has been occurring in Autism Treatment Network sites, which is a group of university-based centers across the country. And I'll just highlight maybe a few that when you look at high-risk toddlers who go on to develop autism compared to high-risk toddlers who do not go on to develop autism, what you see is differences in the way they sleep, motor delay, visual and sensory issues, the way they visually track objects, regression in their development. Certainly the ones that we're familiar with, language delay, differences in the way they play. But for pediatricians in their offices, what I would sort of focus on is the heart of autism, which is delays in milestones related to social communication. The best examples being joint attention and orienting to name. So let me give you an example of this. This is from the autism case training module from the CDC. You can get free CME for this. And so I recommend that you go to this site. But what I recommend is that when you go into a 6 to 24 month visit, the first thing you do is call the child's name. So let's see what happens with good old Kyle here.
Kyle!
Right, so highly technical video. And even points just to make sure you know that he does not have autism spectrum disorder. And then let's look at a boy with autism who has been diagnosed. This is
You want to try to see if you can get him to respond to it?
No.
Evan.
Kyle!
Evan. Evan. See maybe if you can get him to respond to you now that you can use touch with his name, like give him a little tickle or something. Evan. 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 He likes the tickles, but he's just not giving you too much eye contact, but he does smile when you tickle him. Evan. Evan. Evan.
So the truth is probably somewhere in the middle of those two videos with most children with autism. I wish it was that easy to do evaluations every day. But what we're finding out is more recent studies show that children with autism, especially during brief visits in your office, are a collection of neurotypical behaviors and behaviors that are consistent with autism. And there's a ratio. And during brief visits, you may not detect enough abnormal or behaviors that are consistent with autism. So for that reason and many others, the AAP recommends that you do add to your surveillance universal screening at the 18 and 24 month visits. The instrument that's most commonly used in primary care is the revised version of the modified checklist for autism toddlers. And if you administer this test in your office with fidelity, what's been shown from validation studies is that over and beyond your surveillance, you find more children with autism and you diagnose them earlier. So it's very important that once you find early signs of autism and identify children as at risk from either surveillance or screening, that you make these simultaneous referrals to your local early intervention program to start general developmental therapies that can be helpful, audiology to rule out hearing loss, and then on for a comprehensive autism spectrum disorder evaluation. And lo and behold, this is my opportunity to plug our team that does autism spectrum comprehensive evaluations. This is the University Developmental Assessment Clinics within the department here. We provide what I would consider and what the AP would consider gold standard evidence-based multidisciplinary ASD evaluations. And we do it at a volume that I'm not aware of anybody else that's able to pull off. I think that this work is challenging, but I'm really proud. I spoke with our administrative staff the other day, and if you have a child that's at risk for autism based on an MCHAT at 24 months of age and you want to get into our clinic for an autism evaluation, we'll get you in between 3 and 4 months to start that evaluation. That's competitive with any university-based center in the country, and I'm extremely proud of all of the members of UDAC that are here today. This is a phenomenal team to work with. And despite the volume, they do this in a very family-centered way. So, and kudos goes to the leadership of our department who has made the privilege of doing this work possible. So I want to briefly touch on long-term management or ongoing care. This is what happens after the diagnosis is made. And what you'll see for young children right after the diagnosis is these comprehensive strategies, meaning early and intensive behavioral interventions. And those that use a methodology known as applied behavioral analysis, or ABA, have a very strong evidence base for improving developmental and functional outcomes. Certainly for, in terms of more targeted interventions, you'll see children with autism receive things like speech and occupational therapy, social skill groups, and many other things that definitely come into play more as children enter school age. And then for pediatricians, we really focus our efforts on medical management, and the 2 bullets I have there are we evaluate and treat for associated medical and psychiatric conditions, and we make sure that families get to the right services in the community. So by associated conditions, what I really mean is that there are a whole host of psychiatric conditions and medical conditions that children with autism are more likely to have compared with children without autism spectrum disorder. And these conditions can actually, in some cases, be more disabling than the autism itself. And so the implication there is if we can address these, identify them, and treat them, we can improve the functional outcomes of children with autism spectrum disorder. So to give you an example, these studies essentially all ask the same research question: which children with ASD are more likely to have daytime maladaptive behaviors? And from these studies, children with autism who have GI symptoms and conditions, sleep problems or insomnia, epilepsy, ADHD, and anxiety, compared with children with autism who don't have those problems, the first group is way is not a good word, significantly more likely to have maladaptive behaviors during the daytime. Again, implying that if we identify and address these issues, we improve function, we reduce caregiver stress, etc. And so to help pediatricians identify and treat these associated conditions, there have been a number of practice pathways developed through the Autism Treatment Network that help pediatricians take a systematic approach in identifying really common things that exist in this population, like constipation, insomnia, anxiety, and ADHD. So I really encourage you to read those and incorporate those in your practice. I don't have time to really talk about those today, but I do want to spend a little bit of time on this last bullet, which is probably the most common reason that I get called from a pediatrician in the community, and that's for that chief complaint of I have a child with autism in my office with a new onset complaint of aggression. And so I just want to encourage you to read that in its entirety because it's a really rich and meaty paper, but I've boiled it down to what I think are 6 steps. So the first step is to rule out a medical cause. Anything that causes discomfort or pain is in play here, and you can just imagine the number of different things that we've seen over the years. Then I think about sleep. If you can fix a sleep problem, children sleep better, they're better behaved during the day, and caregivers are a lot less stressed because now they're not up all night with their children. Then I think about caregiver stress and making sure that we're connecting parents with the right services, because caregivers that are stressed are less likely to implement the behavior plans that we want them to implement, which leads to more maladaptive behaviors in their children, which increases the caregiver's stress, and on this cycle goes. So that cycle needs to be interrupted. I then think about behavioral interventions. So what I always tell the residents is hitting, kicking, biting, and screaming may look bad to everybody that has to go through it, but if those behaviors are inadvertently reinforced, they become functional behaviors, and there is nothing that you can do to interrupt a functional behavior. So that's why a behavioralist are your best friends when you're confronted with this issue. If you've done all of those first four, and you as a provider can identify a psychiatric condition like anxiety or ADHD, then it's reasonable to carefully think about starting a medication, and Drs. Palmieri and Martini are going to give you some pearls on that. Everything with autism begins and ends with families, so I'm going to end by just reminding you, gently reminding all of you that compared with children with other disabilities, parents of children with autism tend to report that they feel less involved in decision-making with their providers. And so it behooves us to make that extra effort to really try to partner with families, to spend that extra time, to gain trust, because when families with autism do feel like they're involved in shared decision-making, they're much more likely to make informed decisions about all of these things that I'm listing here that frequently come up in your office. So with that in mind, I encourage you to think about scheduling an extra visit between the health supervision visit. We'll call it a chronic care management visit. And during these, you can proactively discuss a lot of the things that I brought up, as well as a lot of things that my co-presenters are going to bring up. And with that, I think I'll bring Dr. Palmieri up. This is your homework. These are all of the papers that I've referenced during my talk. And if you're more into like the whole one-stop shopping, then the MedHome portal is probably the best place to go, because everything I've just mentioned is in the autism module, which is very easy to find. And with that, I will turn it over to Dr. Palmieri.
So I have to thank the good Dr. Carbone for my interest and initial foray into autism. It was his UPIC conference back many years ago that introduced MChat, universal MChat screening, that got me interested, and particularly his video clips. He had quite a few of these, and I thought, wow, that's something I hadn't really understood before that I'm seeing, but now somebody's put some names to it, and he did a lot of teaching with us. And I work at Altaview Clinic. It is a new joint venture of Sandy Pediatrics and Mountain View Pediatrics. So those of you who don't know that we have joined, there's 11 doctors there. We're a special needs clinic, a personalized primary care clinic, meaning that we have psychiatric help, care management, and a patient advocate. I won't belabor this because you've heard a lot of this from Dr. Carbone already about the MChat, but as you're implementing this into your primary care practice, it's important to have a process that works the same way every time and to track how you're doing. And Intermountain tracks this as one of their goals, how many 18 to 24-month-olds are getting their screens, how are those screens being followed up. The follow-up process, there's a set of rather complicated follow-up questions for kids who have failed answers. I've memorized the most common ones, and I do my own follow-up, as do my colleagues. But in some practices, a medical assistant will call on another day and give a full follow-up interview. And then referring, as Dr. Carbone said. I love the videos he showed you, because those are really the two questions we implement starting at 9 months. And I have found that those are almost more effective even than the MChat itself in identifying children earlier. That does your child turn when you call his name? Does your child look when you point at something? I always add the caveat, when they're in the mood. Otherwise, you get a long discussion about how he does it sometimes and he doesn't do it other times. I just say when they're in the mood. We deny parental concerns at our own peril. So studies have shown that when the parent raises an issue, the chances of there really being something developmental is much higher. I would say that parents are less scared of the concept of autism now than they were 10 years ago. They're likely to bring it up, and I'm less afraid to have to say the A word, are you worried about autism? Earlier on, I would be very frightened about saying that because of the panic. But most of them have done some research well before they come into you, thanks to the internet. I screen all my kids with speech delay well after the MChat period. I can continue to screen them all the way up through kindergarten. Some of these kids are subtle and were missed on the MChat. And then my biggest heartbreak are these older children who have not been diagnosed. And part of it was I was a young pediatrician when these kids were younger, and I didn't know what they had. Other times it's been subtle, and as the social differences have increased over time, these children become more apparent. I have any number of depressed and suicidal high schoolers and young adults who were not identified early on, whose social skills have now failed them as their peers have moved on. And one of them recently jumped from a train bridge and survived, but we knew he was autistic. We didn't diagnose it until he was 17, and we could not get a handle on the mental health problems that came after that. This is what we do in our clinic to welcome children with autism. We draw patients in largely off of our Facebook referrals. So don't underestimate the power of social media within these parent groups. We are conscious of that because a good review is good and a bad review is bad. One of our best and our two most strong advocates in our clinic are our care manager and our patient advocate. Our patient advocate does our pre-visit call, and Susan Hansen sets the tone for the whole thing. When a parent calls in and wants a new patient evaluation, Susan calls and identifies all their problems and concerns. She does this with each follow-up visit, which can be anywhere from 3 to 6 months, depending on how the child is doing. The parent is often crying on the phone by the time they're done talking to Susan, saying, nobody's listened to me like this before. So when they come in, they're primed and ready for us to be a service because they've had great service from Susan. Our care managers attend all of our follow-up appointments for that or for things that involve care management. So every 3 to 6 months, these children are seen again, and our care manager puts together a care plan with goals for the doctor and goals for the family, and then proceeds to follow this up over the phone. So these kids are followed really closely, and when they have problems and concerns, I have one that will only talk to Susan. I have several that will only talk to Melissa. And then I get told what's going on because Melissa and Susan have been so much a part of our care team that the parent identifies with them. You can check in from the parking lot. You don't have to wait in the lobby. Our staff knows the sensory issues because Susan is screened for them. And so last week we pulled a rolling stool out of the clinic because apparently that was a distractor for the kid and he couldn't do anything if there was a rolling stool. And then I often just focus on the essentials on my exam, and there's some kids I haven't touched in 6 months, but we just sit on the floor and try to get as close as we can. More people will talk about sensory issues and what those concerns are. I wanted to point out here on this slide that the pediatrician's job is to coordinate with the school. I can't tell you how many times I've called the school only to be told that I'm the first pediatrician that's ever called. I talk with the school about the IEP. I talk with the school about the sensory diet plan. I talk with the school about my med changes so that the kid's increased aggression doesn't lead to him being expelled. And then if you already know about primary children's rehab, I do hope, and you'll hear a lot more about that. Wiggly Worms is a good OT sensory program for children from Easter seals up through the age of 5, 6, okay. These are the behavioral therapies. In-home is really helpful. We love in-home. I have to tell you that it's not well covered under all insurance plans, including our own. It really has been shown, I think, to be the most successful because you can't evaluate these children out of a setting that doesn't include their parents. The waiting lists are really long. This is a medication list that a primary care physician is now going to need to be able to handle. If you thought you could manage SSRIs and stimulants, you were wrong. There is not enough psychiatric availability, and you are often the first line when a kid's aggression is getting out of hand. You need to know what they're using, how they're using, and how to adjust it. And thanks to Paul Carbone and the behavioral health team for their immediate responses when we need more help, but you'll be the one adjusting these. Of course, start very low, go very slow. Paul already talked about making sure that you're checking for other reasons besides just throwing a med at something. I want to point out that our clinic works very hard to be quickly responsive. In my practice, unstable children have my cell phone number. I know that most of you disagree with that, but I'm part-time, and that's the only way I can successfully manage these children. If they don't have someone to reach out to when the problem is happening, then waiting till you're in the office the next time or someone could call them back is not successful. Last week, I had a kid reach out from Amsterdam. He was jumping on the bed, choking his brother in the middle of the night. So we had to talk about why that might be the case. And then, of course, everything falls apart when puberty hits. Be prepared to be very, very versatile. We make med changes frequently, behavioral interventions frequently. These are resources my care manager frequently gives. My favorite is the wandering resources. We have spy network ideas, so you can find your kid anywhere, anytime. You can put spy things over the doors so they can't get out without you knowing, and we have lists of these things. The families love the National Park Pass, and most of them who come to us from other clinics have never heard that you get a free National Park Pass if your child has a lifelong disability. The pediatrician's role, I'm going to kind of skip this slide, is to advocate for the child and advocate for the family. The child and the family are in balance with each other, and often it's way out of balance. So we work as hard for trying to restore balance to the siblings and the parents as we do to trying to help the child get under control. This slide, which I hope you'll have a copy of, is just some great documentaries and books that I have read that help you get inside the mind of people with autism. And that's what I wanted to put on my wish list. It's at the bottom, but it's the one that I feel is the most important. I called it normalization of the diagnosis, and I want to be careful with that word. But it's so prevalent now. How can we decide that these people are abnormal and we're normal? It is much my duty to learn to talk to them as it's their duty to learn to talk to me. And so I find their minds fascinating. I love the fact that we can spend 30 minutes talking about how the fountains in Las Vegas work. Like, who knew? So that's really great. And what would life be like if you didn't have somebody who liked the fountains in Las Vegas? And so rather than trying to make these kids like me, it's important that we help them learn to incorporate. These people work in our environments, at our workplaces, in our schools, in our businesses. We need to learn to communicate with them as much as they need to learn to communicate with us. I would like waiting areas that are appropriately designed for sensory kids. I would like resources, I mentioned this for older children, more therapy accessibility. The waits are super long right now, more psychiatric accessibility, and definitely some plans for respite for families. And with that, I will pass on to the next presenter.
Thank you so much, Lisa. I am Erin McQuivey, and I am a rehab manager, but more importantly to me, I'm also a speech pathologist. And it is my pleasure and opportunity to be able to talk to you today about autism from a tertiary care perspective. I love these kids, and I love the opportunity that I've had to work with them and with their parents, and to continue to do so. As Paul and Lisa have both stressed and talked about, and I've loved their presentations, that comprehensive diagnostic evaluation for autism is a really important piece to the long-term success and support for these kids and their families. But today I want to talk a little about some supports and services that a child and a family can access while they're waiting for an evaluation and continue to access afterwards. So this is my question, and I feel that one of the best things that we can do as providers is to empower parents. The internet is a scary place. You can find anything you want to find there. And so I believe that we first empower parents by listening to their concerns and helping them get to the resources that are available. We know these resources better than anyone. So as these children, as therapists, we evaluate and treat not necessarily diagnoses, but signs and symptoms. And those are things that you as providers are seeing. And these children can receive and benefit from many services, including, and I'm going to focus a little more today on some of those developmental therapies, that occupational therapy, physical therapy, speech, and even feeding therapy without a formal diagnosis. Additionally, let's see. Okay, so it's important to loop a clinician in when you are referring a child that you're concerned about. I love that Lisa said that more families are coming in saying, you know, they're bringing up the word autism. But we still have some families who are a little more reticent to pursuing that diagnosis. I think therapy is a great place to help send and support these kids, because sometimes we see families who they're not ready to pursue that diagnosis, or maybe they haven't heard the word, or maybe you're not able to get a really clear picture of what's going on. But they're coming to you and they have some of those core deficits in social communication. And so maybe you refer them for speech, but maybe it's on your radar and it's in the back of your mind. Looping in the clinician that you're referring to or this facility that you're referring to helps us know that it's on your radar and we can become your some informants and also your advocates as we support families in coming back to their pediatricians to further that conversation about what their child needs to be supported. And so I feel like a couple of things that are really helpful in empowering parents is to give them ways, to research-based information and tools to be able to articulate their concerns and to discuss what they're seeing. There's a lot of verbiage that we are familiar with as it relates to autism that they don't know. I explained to a parent yesterday what echolalia was, and she was like, "There's a word for that." And so we've been having this vocabulary conversation, but that is helping her to open up those conversations and explain what she's noticing her child do. To know when something is disordered, I believe parents have to know what typical development looks like. And there's a couple of great free resources that we can refer families to. Paul referred to this one a little bit earlier. So the Learn the Signs, Act Early campaign from the CDC. You can order free information from them, and it walks through their book, talks about, corresponds with the Well Child Checks, and lists out what milestones kids should be meeting in all areas of their development. I had one parent tell me, "I wish my child was born with this handbook so I knew what to expect of them." And there is now an app. We have joined the 21st century, and there's an app for it that parents can track milestones, share a summary with their physicians, and then get tips and activities to continue supporting their development. Also, the Autism Navigator is a great program and has some great information. It has an ASD video glossary in it that has some videos similar to what Paul showed earlier, so the parents can see what does that look like when it's normal, and what does it look like in a child with autism. I feel like when they can see and have tools to see that for themselves, that can be a really helpful strategy. Support comes in many ways, regardless of a diagnosis sometimes, and it's important to note that as therapists, we have that opportunity to build those relationships of trust with families. And I think that that is a really important piece for some of these families, and to be able to help them navigate some of their immediate concerns and prepare them for navigating some concerns that are going to continue to persist in the future. And so I want us to talk a little bit about what services, some different service lines that come through a medical model versus an educational model. I believe this is a really important piece for us to understand and to be able to navigate. I have to give kudos to Cheryl and the Autism Council of Utah for this handout picture. Colin, she's pointing at Colin, because I love this picture, and I think it's a great diagram of essentially like the ideal. And I want us to note this like communication box in the middle, because that's key. So essentially, we live in a medical model world, and it's important to distinguish that through the medical model, kids can receive a medical diagnosis of autism. And a diagnosis is really a gateway to further services. And some services and service providers, as well as payer sources, such as insurance, require that formal diagnosis for coverage and for access to things such as waivers and other programs. But in an academic setting, children, regardless of their medical diagnosis, are evaluated for an educational classification. These classifications are used to determine eligibility for special education services in a school setting. And there are some different services that support these kids. So I kind of already talked about this, so I'm going to skip to this slide. So we have the early intervention program that serves birth to 3, and then early childhood, and then into schools. And I think it's important to note that while a lot of these therapy services can be provided through a medical model, and through a school model, they both have to work under different laws and regulations. And so it's important to note that services that are provided in early intervention are more family-centered with that individual family service plan, but that shifts during early childhood and becomes determined based on what a child is based on that child being able to access that core curriculum. And that shift can be challenging for parents because they go from being involved to not able to being as involved. And so I think it's important to recognize that while these therapy services exist in both places, their models can look different, and that frequency and duration and that parent involvement can look very different in different settings. I'm grateful to work in a model at Primary Children's Rehab where we have parents in our therapy sessions, and I feel like that is such an empowering model, and to be able to have families with us at all ages. And so with that, my message is communication is key, empower your parents, and refer early. And with that, I am going to turn the time to Rich Martini, who is going to talk about some psychiatric services.
Thank you. Thank you very much. I want to talk about this, kind of just touch on this really quickly. Paul did a very nice job in introducing some of the behavioral issues. I want to talk about some of the challenges for primary care practitioners in working with these patients. I think that clearly behaviors are affected by developmental level. The ability of the child to communicate, the ability of the child to understand the behavioral interventions that you're trying to structure, the treatments that you're trying to implement. The comorbidity of ADHD and anxiety, I think, is quite often challenging. These patients, because the level of their anxiety and the intensity of their obsessive compulsive thinking and behavior, it is often accompanied by agitation. And that if you couple that with a physical condition, not just because of the diagnostic issues that Paul raised, but also because if you think about a kid who has a really hard time with change, environmental change, and is rather obsessive compulsive in their behavior, dealing with a medical illness and all of the sort of unforeseen challenges that come up with that can be very, very difficult. I think the challenges, of course, for a primary care doc is you have 15 to 20 minutes for an appointment. And I think that the concern and the thing to always be aware of is that in that situation, medications become kind of a treatment of choice. And there are limitations around psychopharmacology. And I think it's why some of the behavioral interventions that Paul talked about and Lisa talked about are so important. When you have a patient who has anxiety disorder at baseline, you put them on stimulant medication, sometimes those problems get worse. And you need to be able to differential diagnosis between anxiety disorder and ADHD is sometimes kind of a fine line. Also, if you start them on antidepressants, which is the treatment of choice for many anxieties, it takes time for those things to work. And some of these families are in crisis and they're asking for something to be done right away. And negotiating the medication changes over weeks can be a real challenge. And so what sometimes happens is that we begin to resort to antipsychotic medications. They're effective in the treatment of agitation, but they have significant side effects. And I think the thing that I've found is that once you get a patient on an atypical antipsychotic and they get better, it's very difficult to get them off. The family is very satisfied with the progress. The patient sometimes is very satisfied with the progress, but this is not a medication that you want the child to stay on for an extended period of time. I think that we need to provide more support. We, meaning mental health professionals, need to provide more support for primary care practitioners. We need to think about providing education on the behavioral and emotional problems that frequently accompany the diagnosis. And I know there's some discussion here in the general academic pediatrics program of developing a certificate program, a training program for PCPs to discuss this. There's also, I think, an important opportunity for us to talk about the role of the PCP in treatment. Psychopharmacology guidelines, some sort of sense of, okay, I've got this patient on 3 meds, I'm really pushing the dose. Is this a point where I really should be thinking about referral? We need to talk to them about providing local resources and information about local resources, access to therapists, in-home services. And we also need to continue to develop integrated care systems in which we have practitioners in their practices, but also make sure that there are tertiary care referrals available, whether they're in-home services, day treatment, residential, inpatient hospitalization. It is important to have these available because there are occasional crises for these patients. And I think pediatricians need to know where to go and who to talk to. So now I'll pass this on to Colin to talk a little bit about community resources.
Hi, thank you guys for having me. So I'm here to talk to you about Community Support Network. So I'm going to discuss access issues, wait time for an evaluation and services, the Utah State Plan for Autism, and services in those pesky rural communities. So first, in Utah, parents face access issues all along this continuum. So when we're looking at screening, only 44% of kids who are diagnosed with autism received an MCHAT screening at the appropriate ages. So that's a pretty low number. Evaluation, only 36% of kids were evaluated with developmental concerns before 36 months of age. Nationwide, I think that number is 43%, so we're kind of below the national average there. Treatment and therapy, as mentioned earlier, it's a really long wait list to get into a lot of these ABA providers. Some of them have 6 months, and in rural communities it can be even longer. I'll touch on that more in a moment. When looking at education, what is an IEP, as mentioned earlier? A lot of schools have a lot of issues with this too. They don't know what services they should be offering to the kiddo. And then mental health, as Paul mentioned earlier, when parents are facing mental health issues with their child, a lot of times they don't know where to turn at all, and those wait lists are pretty long as well. So wait time for an evaluation, UDAC is kind of alone in their 3 to 4 month wait lists. Many of these other providers have a 6 to 8 month wait list, and some of them are even longer. If you're looking at a provider in a rural community, it might even be a year. That's a lot of time to miss for a kid getting into some treatment. Mental health, I mentioned, is about 7 months. But for parents in the community overall, the process doesn't end with the diagnosis. So once they get that, diagnosis, what do you do after that? As I mentioned, services in rural communities. The Utah Department of Health does not offer traveling clinics to rural areas anymore. We're working on that, but it's a long road to hoe to get providers down there to go to Blanding or Moab. So what we're looking at is most providers are bunched along the I-15 corridor or on the Wasatch Front. We have huge gaps of service on the eastern side of the state. So Vernal, Blanding, Roosevelt, Moab, it's kind of a dead zone. Our ABA providers in those areas are usually at full capacity. I'm happy to give a parent a name of the 2 ABA providers that serve their area, but then they have to wait for a kid to age out until they can get a phone call. So what can we do to do better? How can we help? In our Utah State Plan, we determined that we need to better coordinate our efforts. A lot of times everybody doesn't know what everybody else is doing. So we have the thing called the Utah Autism Initiative, where folks get together and tell us about what they're doing here, what other people are doing, just to kind of help spread the knowledge around. Services, we're always working to help people know what services are available in an easy to read fashion. I always talk to Cheryl about this. It doesn't help you if I give you a laundry list of services that you have no ability to read while the kid's climbing on you and pulling your hair. That's not helpful. We also need to make sure that the services we're referring to are up to date. A lot of times you'll read at the end of an eval, take them to this place for ABA therapy. That place has been out of business for 6 months. So the parent starts calling around and they're all out of business, and that's a little frustrating as well. As I mentioned, service access in rural communities. A lot of these kids in rural communities don't even have a primary care physician. So who's going to administer that MCHAT? Who's going to refer them to services? So we have to think about other ways of accessing that community. We also looked at training. What can our community do better to embrace folks with autism? Can we train a business to say, this kid has autism, these are their strengths. How can you incorporate them and help your business out? There's a lot of great examples of this. And then person and family centeredness. This one's really important to me. You know, you have to help parents help themselves. The Parent Center is an incredible resource to this. Family to family, you know, with that parent who's been through it. When a parent can call up another parent, it's an incredible bond that happens, and they can help them coordinate services like a care coordinator cannot. So Gina's group offers that resources and is incredible. And then research, you know, as Paul mentioned, the prevalence rates are always changing. The Utah Registry of Autism and Developmental Disabilities has our prevalence number, and in Utah specifically, it's 1 in 60. That was released in 2014, and we're hoping to have some updated numbers later on. And then great research, you know, IHC spearheaded a research project looking at whether labor induction and augmentation could be a causal factor in autism. It was not, so that's great news. It was a null finding, so it didn't get a lot of press. But and then these are some resources that you can go to. They're just Google short links, so you can find an evaluator. That list is kept up to date. Great help to the medical home portal, which is another incredible resource for you. ABA providers, like I said, we have to keep this up to date all the time because a lot of them go out of business, unfortunately. And then those are some other resources provided by the Utah Autism Initiative. And with that, I'll turn the time over to Cheryl.
Hello, I'm Cheryl Smith, more commonly known as Carson's mom. I have a 20-year-old with significant autism. I like to call it autism, well, now I can't even remember, plus. He's 20 years old, 6 feet tall, 280 pounds, which is down 35 with the help of Dr. Carbone and Dr. Builder getting him off his Depakote. And thank you all for being here. It takes a village and a small country maybe to raise these kids with autism. It's nothing easy about it, but it's also very rewarding. I wanted to talk about a parent's perspective. The Autism Council of Utah is a great resource, and I left some brochures out on the table. One of our projects right now that we have going is to take those materials to pediatricians' offices so that they can give them to the parents. I had a cartoon of a man in the water, and they threw him the life preserver, but it wasn't hooked to the ship. And I sometimes feel like that as we're getting the diagnosis of autism, but then there aren't resources for us, and we don't know where to go from there. So the Autism Council of Utah is there for the parents. We put all the resources on there that we know about in the state of Utah so that parents can access those. Of course, everyone knows about the Utah Parent Center and the portal. The National Parks Pass Lisa mentioned, but there's also Disneyland Pass, which, you know, when I go to Disneyland, I put the t-shirt on him that I made that says, "Autism isn't the tragedy, running out of bacon is." And also ignorance, but mostly the bacon thing. And then everybody knows, and I don't get the stink eye so much. So, and local autism accommodations, sometimes it's just telling the parents to ask. You know, when I go into a movie, I say right away, now he has autism. If he doesn't stay more than 5 minutes, can I get my money back or come again? Or they let him go do things. You just have to ask. We have a lot of support groups in our state. We have one in Utah County and one in St. George. And this is my support group. I'm the co-queen of the Big Macs. And our tagline is more support than a 44 double D. And I don't know if some of you fellows know, but that's a lot of support. We go to the cabin once a year, just the moms, no boys, no kids. And you'd think that we would just not talk about autism, but we laugh all night and talk about poop. Can I say poop in here? Yeah, that's what we do. So I did a survey of the Big Macs, and there's 1,200 Big Macs on my Facebook page, and I have a list of everything they love about their pediatrician and everything they hate about their pediatrician. So I'd be happy to share that with anybody, but here are a few of the highlights. On-time appointments, run a tight ship was the exact words. Having the special wait areas and things that Dr. Lisa talked about. Being current on autism and consulting with others if you have questions. being accommodating. I don't know how many times I've been told, yeah, but we'll do this other thing. And that was before I had Dr. Carbone. No, really, he stopped talking. He was talking and he stopped talking. Isn't that weird? No, no, let's wait and see. Discounting what the parent says is not a good thing. Coordination and explaining what you're doing to the child. I'm not going to sneak this shot in. I'm going to show you, this is what I'm going to do. Touch the shot. I'm going to put it in your arm now, that kind of thing. This is my boy Carson. I thought I'd just throw in that special picture. They hate waiting. They can't even wait for the ride at Disneyland. So waiting at the doctor's office is extra hard. And I told you discounting concerns, not talking directly to the child, like they're not even there because they don't speak, or maybe you think they're severely affected. They can hear you, and a lot of times, I think Carson definitely knows if people like him, if they're talking to him. And not having autism specific knowledge. And I know that's tough because it's a huge spectrum with lots of little things that you need to know. There are a lot of alternative treatments out there, and I've given the resources to find those. And we also have a document that we've put out by the UAI, the Utah Autism Initiative, about the medical and educational changes that Erin talked about, but also looking at alternative treatments with a skeptical eye. You know, do you really want to put your money there? You really need to look at those and see what's the research behind that, because a lot of things are out there and we don't know what's going to work and what's not. So in a nutshell, as a parent, validate the parent's perspective. And you can be honest and say, I don't know that, but I'm going to find out. And because you're here and you care, we love you. And that's it.
That was fantastic. Thank you, Cheryl. I don't know if you guys want to come up, but we do have a couple of minutes for questions, comments. You can direct it to us generally or to anybody specifically. Anybody have any questions?
Thank you very much for your presentation. Appreciate all the work that you guys do. In particular, I just want to point out to Lisa and Paul. So I'm one of our emergency doctors, and I really appreciate how strongly you advocate for your patients. And you know, we see them often, and really appreciate what you do. So as mentioned, I'm one of our emergency doctors. This is a significant area for improvement in our department, and one that we are currently embarking on. I'm wearing fancy pants today, so I stated my question that way. If I were wearing scrubs, I said, we suck and need to fix it. So we are starting on this road. And in terms of your expertise, all of your expertise, what would you say are the key things that we need to do in the emergency department to make this a better environment for our patients with sensory processing issues?
We are in the process of making a toolkit for the ER. Yes, we are. Headphones, sensory toys, writing tablets, that kind of thing, because you don't have that when you have an emergency. But when I go in with Carson, I say, give him Versed right now or give it to me, because one of us needs it really bad. And I've had the best experience I've ever had at primaries, and I've also had the worst experience I've ever had. This whole thing where they can't wait, they can't be in the area with everybody, just understanding and listening to the parents. This is what I need right now. Will you please get him out of this area? And having things happen, I know that's hard in the ER, but on time. You know, if you're going to release me, don't wait 4 hours to let me go.
And I think it's the primary care doctor's duty to call ahead when you're sending a child into the emergency room. I tell them what the question is I'm asking, what kind of sedation or help I think the kid's going to need, and what the sensory issues are. And I have found the ER very responsive to those calls.
Any other questions? Up here.
Evaluations for autism. My understanding is the Developmental Assessment Center goes how old, and then the other question I've run into is cost for families who, and getting that covered.
So I'll try to take the first question first. So we see all pediatric patients, so through adolescence, like all the other clinics. we see. So hopefully that answers that. Now, the wait list is a little bit longer. What we've done is because of the data we showed you about young children needing access to early and intensive behavioral interventions, we've had to adjust our care process model so that we prioritize getting young children evaluated first. So school-age children, older adolescents would have a little bit longer of a wait period. And then your last question was related to cost for families to access UDAC. And we work with most insurers. So from what I think about half of our population has Utah Medicaid, and we accept that insurance. So, and then we work with families. I'm looking at our administrator saying, Paul, tell people that we work with families, and we have.
Do. And they can work through medical billing at the university.
And they can work through medical billing through the university and access sliding scales and things of that sort.
Here's a question.
Great, another question?
What about some of those cases that I'm a social worker that we run into when we're working in the ER of the parents are coming in and their kid has gotten out of control, they feel that they can't control them anymore and are kind of at the end of the rope with behaviors and that sort of thing. And I can't always do a whole lot when they're wanting them placed in a psychiatric facility, and that's just not something you typically do. And so what sort, other than like referring to the JRC or in other community resources, what other things are parents looking for in that sort of situation?
You know, I could probably talk a bit about that because I think for us in our department, this is a very important issue. We are trying, I think, to not only develop a crisis screening process that identifies what are the most important risk factors in evaluating individuals with autism when they get agitated, to look for not just kind of fitting in with what people have talked about, not just how the patient is presenting, but what are the capabilities of the family. Because really when it comes down to it, you're thinking about safety. How safe is that child? How safe is that family? How safe are the individuals within that environment? And if you're in a situation where the family's capabilities are limited and you're worried about that, an inpatient hospitalization, psychiatric hospitalization may be necessary. I think what has to follow, and I think one of the areas where we in mental health have to work a little bit harder, is developing specialized programs within these psychiatric units to address their needs, to be sensitive to all of the issues that people have talked about that these patients present with. And it is a challenge. And I think it's one that we in mental health have got to meet.
A few months ago, I'm a psychologist, and I have a peer supervision group I meet with the other psychologists, and talking about the fluctuating levels of incidence of autism. One of the things I'm wondering what if this impacts it is we talked about the pressure in the last number of years as there have been a lot of services that have opened up for kids with autism, but you need the autism diagnosis. And we'll have children come in who maybe don't meet the criteria for autism, but there's a lot of pressure for parents to want the child diagnosis having autism so they can get access to services. Do you think that's affected the incidence?
Actually, the prevalence numbers for autism in Utah have been level for about the last 10 years. So what URAD does is it looks at the administrative prevalence, so kids diagnosed with autism. So that's an actual diagnosis. It's a little bit different than what the CDC does. And we've seen that 1 in 60, 1 in 70, 1 in 60 number be pretty consistent.
So this is Sarah Winter. I'm the medical director of the Developmental Assessment Center. I just want to point out that people across the country are struggling with the geographically remote populations, and Colin alluded to that challenge. One of the ways that people are looking at, and Paul and Kendra Lystad, who's here, are going to present on our experience with telehealth. That's, a sort of emerging technology that people are trying to use and insurance companies are embracing. And we're actually seeing approximately 30 to 40 kids a month via telehealth. So it's not the perfect solution, but it is a opportunity to improve and get access to our rural populations.
Any other questions?
One quick question.
Thank you. So I'm actually a resident at the Shriners Hospital, and I'm doing prosthetics and orthotics right now. So the other day we saw a kid who had scoliosis, and it requires us to do a casting of these kids, also for lower limbs, and that can be very, very difficult because it's very restrictive. I just wanted to get any suggestions, hints on that. It's very, very difficult, and I was just wondering if you have any thoughts on that.
So I might have some friends who might be able to help you with that. Because I work with physical therapists who have found themselves in similar situations, and we work very closely with our occupational therapists who have provided a number of suggestions. So reach out to me at Primary Children's Rehab.
Can I ask a question? The standard of care is to do genetic screening or offer genetic screening, and with the departure of Lineagen, I don't know what to do now for offer for genetic screening. The lines at our genetics clinic are 6 to 12 months out, and what are you guys doing for genetic screening?
Anybody know? Oh, yes, Sarah's got an answer.
So, welcome to the world. This is a phenomenon happening all over the world. And the insurance coverage is being capped, and the information that we get from genetic screening is growing tremendously. Actually, why am I answering this question? It wasn't John Kerry here.
He left.
Oh, he left. It's an unanswered question right now, and yet it's frustrating because I think parents are asking that more, and we can find more information. It's just not getting reimbursed.
If I were to
And
put
that's
these kids
the
in line
truth of
in
it.
genetics, I would overwhelm genetics.
And it's not 6 to 12 months, by the way. It's 2.5 years.
Okay, yeah. I don't even send the majority of my kids because of the late. So.
My guess is that this great panel would be willing to chat with us after we close, which we have to do now. Thank you, everyone, and thank you to our panel.
Thank you very much for coming. Thank you. Thank you, guys. That was excellent.